Thank you very much for the introduction, and thank you very much for the Emirates Society of Internal Medicine for inviting me. I'm going to talk about biologics, what internist needs to know. So it's going to be not going into details about mechanism of actions or specific side effects, but a general overview about if an internist comes in to see a patient and if they are on biologics, what to look for. So objectives of this talk are pre-treatment screening with biologics, managing comorbidities with biologics, pregnancy and breastfeeding on biologics, vaccinations and biologics, and then some details about perioperative management of biologics. So the biologics which I'm going to talk about today, these are the ones which we use in rheumatology, or what we call them as immunomodulatory agents. I mean, these days you have biologics for all sorts of things, but these are, generally speaking, we will be talking about the immunomodulatory biologics today. So what are the pre-treatment investigations which should be done in all the patients who are receiving the biologics? At baseline, we do, full blood count, renal, kidney function test, TB quantiferon, hepatitis B surface antigen, hepatitis B core antibody total, HCV, HIV, and a chest X-ray. So patients receiving rituximab, which is a B-cell depleter biologic, baseline immunoglobulins such as IgA, IgG, IgM should also be checked. And patients who are going to start biologics such as tocilizumab and JAK inhibitors should do a baseline lipid profile. So why do we do TB quantiferon? Basically to look for latent TB. So patients who are positive for TB quantiferon and you don't think that they have an active TB, they should receive a prophylactic treatment for latent TB. And therapy with biologics can be commenced after 1 month of treatment with prophylactic anti-TB agents, and patients should be monitored for every 3 months while on the treatment. So what if you found somebody to have an active TB? So patient with evidence of active TB should be treated before we start the biologic agent. And the therapy should be commenced after completing at least 3 months of anti-TB treatment. And there is no evidence of infection, and the culture should be negative. So hepatitis B and C, so patients who are hepatitis B positive, they are at risk. You should do a risk-benefit assessment. And biologics may be safe if appropriate antiviral treatment is given. So discussion with the hepatologist is important here. And there are studies to suggest that the biologic therapy, they do not have a detrimental effect on the hepatitis C infection. And you can continue biologic therapy in these patients, but always have a discussion with the hepatologist and the patient with the risk-benefit ratio. And for hepatitis C, there are very good treatments available. So always best if the patient has a PCR positive hepatitis C infection. So discuss with the hepatologist regarding treatment for that. So in HIV patients, so treatment should be discussed with the HIV specialist, but the studies suggest that there is a benefit-risk ratio in favor of treatment with the anti-TNF agents in HIV patients if their HIV infection is controlled. So which is CD4 count of more than 200 and the viral load is undetectable. And anti-TNFs are usually given in combination with antiretroviral therapy. So what about malignancy? So biologic therapies, they should not be commenced in patients with clinical signs of or under investigations for malignancy. And patients should be advised that there is no conclusive evidence for an increased risk of solid tumor or lymphoproliferative linked with biologic therapy, but an ongoing vigilance is required. And there is a conflicting evidence regarding a risk of skin cancers with anti-TNF therapy, and patients should be advised the need for preventative skin care and skin surveillance, and if they find any new lesions, they should have a discussion with the dermatologist. There is a caution in patients with previous malignancy, so it's not a contraindication, it's a caution. Timing of commencement of biologic post malignancy. So patients who have a previous history of malignancy, when to start the biologic. So there is no kind of consensus on when to start the biologic. So it all depends on the type, stage of malignancy, risk of metastasis, and discussion with the patient. So generally speaking, in patients who have a previous history of malignancy, with no current malignancy, we give them biologic therapy 3 to 5 years after previous malignancy. So that is about TNT-TNFs. But patients who have a history of malignancy, they can receive the rituximab therapy. And it should be considered as first line if the patient has a history of rheumatoid arthritis. However, if the patients have spondyloarthritis, they can be given IL-17 inhibitors, IL-23 inhibitors. They are considered relatively safe in patients with history of malignancy. What about the pre-malignant conditions? So effect of biologics on pre-malignant conditions remains unclear, and there is a caution in the use of biologics such as anti-TNFs. However, as I said before, rituximab, IL-23, IL-17 inhibitors can be used. So patients with cardiac problems. So anti-TNF should be used with caution in patients with class 3 and 4 heart failure. And biologic therapy can be used safely in patients with previous history of myocardial infarction or cardiovascular events. So coming to the respiratory problems, so patients who have pre-existing interstitial lung disease, so biologic therapy is not a contraindication. However, the patients may have already got a low respiratory reserve, and in case of an infection, that low respiratory reserve puts them at increased risk of having a severe hospital episode, maybe admission to ICU. So as such, ILD on its own is not a contraindication, but you have to discuss with the patient about risk of infection, and then discuss with the ILD doctor as well about the treatment which you are going to plan. And rituximab and abatacept, they are considered safe as first-line biologic in patients with interstitial lung disease. And IL-17, IL-23 inhibitors, they are first-line agents in spondyloarthritis patients. So demyelinating disease, anti-TNF therapy should not be given in patients where there is a history of multiple sclerosis or other demyelinating disease. Consider using non-anti-TNF biologic agents. So diverticular disease, this is oftenly overlooked. So usually it's safe to give them biologic except for tocilizumab. So patients with diverticular disease, better not to use tocilizumab. So that was about the pre-treatment screening. Now, next I'm going to talk about the comorbidity management. So if the patient comes to you with a problem and they are already on biologic, so the first and foremost is the infections. So all biologics, they should be discontinued in the presence of a serious infection, but they can be recommenced once the infection has resolved. And patient commenced on biologic should be closely monitored for tuberculosis infection while on treatment and at least for 6 months after stopping the therapy. Patients on biologics who develop symptoms suggestive of tuberculosis, they should receive full anti-TB treatment, but they may continue with their biologic agent if clinically indicated, and you have to discuss the risk and benefit with the patient as well as the person who is treating the tuberculosis. So what about opportunistic infections? So you should always have a high index of suspicion for atypical and opportunistic infections, especially if the patient is currently using steroids with biologic agents. Biologic agents should be stopped if you suspect a patient to have an opportunistic infection. And if the patient is exposed to primary varicella through a household contact, and the patient previously did not have a varicella zoster vaccine or a previous varicella zoster infection, so post-exposure prophylaxis with varicella zoster immunoglobulins is advisable in these kind of patients. If patient develops shingles, the shingles should be treated conventionally. So progressive multifocal leukoencephalopathy, this is primarily can be a side effect with rituximab treatment, but it can be associated with anti-TNF agents as well. So if you think that the patient has developed progressive multifocal leukoencephalopathy, their rituximab or the anti-TNF agent should be stopped, and they should not be restarted again. So what about hepatitis B and C infections? The close monitoring of the liver enzymes and hepatitis B viral load is recommended in patients with occult or overt HBV infection while on biologic therapy. And same is for the HCV infection. And the patients who have evidence of occult HBV infection, they may require concomitant antiviral treatment if detrimental changes in monitoring test develops. So these are the current recommendations for hepatitis B infection. So if the patient is hepatitis B core antibody positive and you are planning to give them a rituximab treatment, so you should give them prophylactic antiviral. If the patient is hepatitis B core antibody positive and hepatitis B surface antigen positive, and you are planning a treatment with any biological DMARD or a targeted synthetic DMARD, you should give them antiviral treatment. So the third one is the important one. So the patient who have a core antibody positive, but they are surface antigen negative. So that means that they have an evidence of past infection with hepatitis B. So in these patients, if you're planning to give them any biological therapy except rituximab, or you're planning to give them the targeted synthetic DMARD, so the only thing here is the rituximab. So beside rituximab, you can give them other biologics with close monitoring. And you should discuss with the patient that there is a risk of hepatitis B reactivation because they have a previous hepatitis B infection. However, if you're planning to give them rituximab, they should receive antiviral therapy even if they are HBs antigen, surface antigen negative. So patients who develop HIV receiving anti-TNF, they should be closely monitored for the viral load and CD4 count. And then the treatment changes can be discussed with the HIV specialist. So what about if the patient develops malignancy while on biologics? The patient should be investigated for potential malignancy if there are clinical signs, symptoms, and biologics should be stopped even in case of non-melanoma, non-basal cell carcinoma malignancy is confirmed. In patients with basal cell carcinoma, biologic therapy can be continued provided the basal cell carcinoma is fully excised after careful discussions with the patient and the risk benefit. So if the patient develops heart failure while on anti-TNF, consider stopping the anti-TNF therapy if you think there is no other cause to explain the patient's heart failure. So in those patients, non-anti-TNF biologics or targeted synthetic DMARDs will be preferred over the anti-TNF ones. So the main ones which can be associated with heart failure are the anti-TNF biologics. So patients who have interstitial lung disease receiving biologics, they should be regularly reviewed with the respiratory physician or an internist with or a doctor with a special interest in ILD. They be advisable to do a pulmonary function test every 4 to 6 months. And the patient's consideration should be given to stopping anti-TNF therapy in patients with worsening or new features of interstitial lung disease. And rituximab and abatacept are considered to be safe in patients who have interstitial lung disease. So if the patient develops demyelinating disease while on anti-TNF, so anti-TNF should be stopped and they should not be restarted again in patients who have any kind of demyelinating disease. Diverticular disease, if the patient develops diverticular disease and perforation while on tocilizumab, do not reintroduce tocilizumab. So some patients can develop connective tissue disease-like symptoms while on anti-TNF therapy. So just a positive serology, for example, a positive ANA or positive double-stranded DNA, is not enough to classify them as having a connective tissue disease. So if they have clinical signs, symptoms of connective tissue disease while on anti-TNF treatment, then you should stop the anti-TNF treatment and give them an alternative biologic agent. Hematological disorders, patients, they can continue biological therapy if there is increased risk of venous thromboembolism. However, I put here, try to avoid JAK inhibitors in patients with risk of VTE or a history of VTE. Choose other treatment options. So some patients, they can develop psoriasis while on anti-TNF therapy. So in these kind of patients, you can discuss treating them with alternative biological agents. So these are some of the percentages. So you can see that the risk of infection, serious infections, is about 3%. This is with the anti-TNF therapy. Skin infections is 1 to 20%. Tuberculosis, 0.05%. The risk of non-Hodgkin lymphoma is 0.06%. And the risk of heart failure, serious liver injury, and multiple sclerosis, this is only case reports about that. So what about pregnancy and breastfeeding? So this is the question which is commonly asked by the family doctors and the internal medicine doctors. So what should we do about these patients? So these are the guidelines, current guidelines for pregnancy and breastfeeding. So you can see here that the anti-TNF medications, which includes infliximab, etanercept, adalimumab, certolizumab, and golimumab, so these are generally okay to be given in pregnancy and breastfeeding. So usually up to 6 months of pregnancy, everything is fine. In the last trimester, you have to discuss with the patient. There is no teratogenicity, but you have to discuss with the patient about the vaccination of the newborn. So if somebody is exposed, if the fetus is exposed to a biological therapy in the last trimester of pregnancy, do not give them live vaccine after birth. So they can have the killed vaccines, but they cannot have the live vaccines after birth. So this is the only thing you have to discuss with the patient. Otherwise, in the first 6 months and in the breastfeeding, so you can continue all the anti-TNF agents. So what about the other biologic agents? So you can see here for all the other biologics, which is rituximab, IL-6 inhibitors, IL-1 inhibitors, IL-23 inhibitors, IL-17 inhibitors, they should be stopped before pregnancy. There is currently not enough data to support their use. And in the first trimester and second and third trimester, it says here, severe disease if no alternatives. So if you think that the patient needs treatment and you have no other option, and you think the patient's disease is severe enough to need a biological therapy, and then you discuss the pros and cons of treatment with the patient, and then you decide about the treatment. And these are okay, these are all okay in the breastfeeding. What about JAK inhibitors? JAK inhibitors, there is currently very limited data. That is why they should be stopped 2 weeks before the conception, and advisable not to use them during pregnancy and breastfeeding. So vaccinations, this is an important question which is commonly asked by the other physicians. So which vaccines can be given? Can we combine the different vaccines? When to give a vaccine? And killed versus live vaccines. So combining vaccines. So giving multiple vaccinations on the same day, this is from the American College of Rheumatology. So they recommend that if you have a patient who needs different vaccinations, it's better to give them on the same day rather than giving them on a different day. So this is the table about the non-live vaccines. So there is influenza vaccination, and then we have other non-live attenuated vaccines. So if the patient is on methotrexate for influenza, it is recommended to hold methotrexate for 2 weeks before giving the vaccinations. That is to improve the efficacy of the vaccine. It doesn't have side effect even if you give it with methotrexate, but if you stop methotrexate 2 weeks before, there is high chances of developing better immunity. Other vaccines, you can give them anytime while on methotrexate. So rituximab, you can continue the rituximab treatment with influenza vaccination. With other non-live vaccines, the rituximab should be timed, and the recommendation is that it should be given because the rituximab stays in your system for about 6 months. So it's better to give them at the end of 6 months, and once you give them the vaccine, you restart rituximab 2 weeks after. Again, this is to do with the efficacy of the vaccine rather than any side effects, because if you give them a rituximab and you give them a vaccine soon after the rituximab, they may not develop the appropriate immune response to the vaccine. What about the all other immunosuppressives? So all other biologics, you can continue all of them in the non-live vaccine. So there is no about the timing and nothing else. So for anti-TNF inhibitors, IL-17, IL-23 inhibitors, you can give them non-live vaccines anytime. So steroids, this is very important. So you can see here that the patients who are on more than 20 milligram of prednisolone daily, so the only thing here is that if you are giving them any other non-live vaccine beside influenza vaccine, better to defer it till their dose is less than 20 milligram. This is again to do with the efficacy of the vaccine rather than any side effects. So these are for the live vaccines. So if the patient is going to have a live vaccine, these are the time intervals. So generally speaking, all the conventional disease modifying agents, which is your methotrexate, sulfasalazine, mycophenolate, you have to stop it 4 weeks before the vaccine and 4 weeks after the vaccine. So for the biologics, it all depends on their half-life. So you can see here it says you have to stop it 1 dosing interval. So if the patient is taking a weekly biologic, so you have to stop it for 2 weeks before you give them the live vaccine, and you have to restart it 4 weeks after giving the live vaccine. So after the vaccine, the time duration is 4 weeks for everything. So if somebody has taken a live vaccine, do not give them any biologic or conventional DMARDs for at least 4 weeks. And if somebody is already on it, when to stop it, it depends upon the half-life of the drug, and it's mentioned in this table here. So rotavirus, this is another important thing. As I discussed earlier, that the fetuses who are exposed to the biological agents in the last 3 months or during the first 6 months of the life. So with regards to rotavirus is a live vaccine. So you can continue giving them TNF inhibitors if you plan to give them the TNF inhibitors. However, if the patient is going to have a rituximab, they should not receive and the fetus is exposed to the rituximab during the first 6 months of the life, then they should not be given the rotavirus vaccine. Better to delay it after 6 months. Perioperative management. So if the patient is going to have a surgery, for emergency, obviously you cannot do anything. You proceed with the surgery, you continue with their conventional DMARDs, and for the biologics, you restart it after 2 weeks of surgery. However, the patients who are going to have an elective surgery, if they are currently treated with the steroids, minimize their steroid dose to less than 10 milligram. If the patient is currently having a conventional DMARD, the conventional DMARDs such as methotrexate can be continued. Biologic DMARDs, again, you have to start it for 1 dosing interval before the elective surgery, and you can restart it 2 weeks after the surgery. So again, this is to do with the dosing intervals here for the biologics, and it all depends upon the half-life of the biologic. So you can see that the second one is the adalimumab. So the dosing interval is every 2 weeks. So that means that you can do a surgery in week 3 if this is an elective surgery. Etanercept is a weekly injection. So the surgery can be done in week 2 after etanercept injection. And same goes for all others. It all depends upon their half-life. And as soon as the half-life of the drug is over, so you can do the surgery in those patients. So what about JAK inhibitors? JAK inhibitors are actually daily medications, and so the half-life is shorter, so therefore the surgery can be done on day 4 after stopping the JAK inhibitor. What about the other conventional disease-modifying drugs? So this is especially, this table, the lower part of the table is about the lupus patients. Because in lupus patients, some of them can be very sick. So, but if you have a patient who does not have a severe lupus, you can stop their medication. For example, mycophenolate, which is given twice daily. So you can stop the medication and surgery can be done 1 week after the dose. And same is for the other conventional DMARDs such as azathioprine and cyclosporine. However, the guidelines are a little bit different for patients who have a severe lupus. So in patients who have a severe lupus, for example, lupus nephritis, in those kind of patients, it's not recommended to stop the treatment. And you should continue the DMARD during the perioperative period, and they can even have it after the surgery, and you can do surgery at any time. So this is for the lupus ones, patients who they can continue the treatment. You don't need to stop the patient in severe lupus patients. And thank you very much.